Hello, good evening to everyone. Thank you for joining us again for one of these very important discussions. It's taken me some time to pull all these people together, and we apologize. Dr. Robin Rose was unable to join us, but in replacement, I've managed to get Joachim Gerlach from Germany, who's been doing a lot of research in the background. Essentially, my mind has now become really focused on how do we mitigate clotting around this virus? Anyone who has been following recently in the past week, I've been given very important information from contacts in different parts of the world who have been working and finding out information that is pretty serious. Now, one of the things that they had identified was a specific sequence in the virus that doesn't seem to have any specific role, but based on the research around the patents and the contracts, it seems as though it was designed specifically to cause clotting. Now, we don't have confirmation of this as yet, but we do know that clotting is a really important factor that occurs around the infection. So, what I'm doing today is pulling people together to try and understand what could be happening and critically, what we could do about this. And so I've got with me today usual Dr. Chetty, Dr. Comrie, and Joachim from Germany. We'll start with you, Charles. If you just do a very quick introduction, then we'll do Joachim, and then we'll do Shankara. If you just say something about yourself, Charles.
Okay. So I'm Dr. Comrie. I graduated from medical school in 1992. I'm a general practitioner. But while we were doing medicine, of course, we were trained to do autopsies. And in rural areas, we learned to do what we call cause of death examination of people who have died suddenly and had not seen their doctors for a while. And the relatives needed a certificate of death so that they could bury their loved ones. So over the years, I've done hundreds of these examinations. And during COVID, although the numbers fell because there was the fear, everybody who died, they thought perhaps died of COVID. And so nobody wanted to get near some of these bodies. So doctors would write death certificates. And so there were less bodies being examined. But I had the opportunity to examine a few bodies, and I did find some strange things like clots in the mesenteric arteries, large clots in the atrium, and large blood vessels. And because I was treating patients for COVID, even in the hospital setting, and I'd seen patients come in with stroke post getting the COVID vax. And they were like a 19-year-old, was quite well, got a shot. 2 weeks later, he had a massive stroke on the left side. And so having seen those and then seen these findings at autopsy, it kind of arose my attention to the whole thing. So that has been my experience.
Yes, don't worry, Charles. We will come back to that in a little bit more detail. So we'll come back to that, but we'll get Joachim to just do a quick introduction of himself, and then Shankara.
Yes, hello, good evening, everybody. My name is Joachim Gerlach. I'm a COVID-19 researcher, and I've been on this case since day one, so more than 5 years, 7 days a week, 24 hours practically, and working with many experts around the world in many collaboration groups, running a lot of laboratories and university studies, and I'm developing dietary supplements and interventions that will help people to get better.
Excellent. And Shankara?
Hi, I'm Dr. Shankara Chetty. I'm a frontline COVID doctor, a general practitioner from Port Edward, South Africa. I have a background in microbiology, biochemistry, genetics, and advanced biology. And I think I can call myself a global COVID disruptor. So
Excellent, excellent. So listen, as we were saying, and Charles was talking about those autopsies, I just want to make it clear to people is that the reason why Charles is important is because he is the first doctor to come forward and say that he has been seeing unusual clots similar to what the embalmers have been seeing. Now, a lot of people didn't believe this was happening. I can't understand the scientific community, because if embalmers were seeing it, what are the chances that nobody else is seeing it? So this is why this is such an important piece of that puzzle. So continuing your discussion, Charles, when you think about the clots that you have been seeing, what would you say was the most unusual characteristic? Were they all big, or were some smaller? What were you seeing?
No, some were very small. And those are the ones that I found, for instance, in the patient who died with abdominal pains. And when we opened him up, and I saw just like about 4 segments, about a foot long, which of his intestines that were necrotic. And so you find there were small blood vessels, that there were clots, arteries that were blocked off, and his intestines in chunks were dead. So it's not as if there was one big clot that took out the whole supply. It was just small areas. But then the I think the most frightening one was when I did the autopsy on one guy. I think he was 72 or something like that, and I found a clot in his right atrium, and I was pulling, and I got a foot-long clot, which was mostly white, and that one was a bit shocking as well. So yes, I've seen both sides, the big ones and the small ones.
Yeah, that's so. And it comes now, Joachim. I'm going to pull up some of your slides, and I want you to take us through quickly what it is you've been seeing in the lab, and then I'll ask Shankara some thoughts about what he thinks at the moment. So, what is this here?
Now, this is a small presentation I put together, and we call it the calamari project because Charles was describing the texture and the structure of these larger clots. They look like calamari. They have a consistency that is similar to calamari. And so you see that on the right upper picture there. These are some smaller ones, but like Charles said, you can have them also in a considerable size, and they look almost like a cast taken out of your artery system, for example, or venous system, depending. And so we've been working on the coagulation disorders since day one, actually. And you can see on these slides on the very left side, you see the microscopic, that's a atomic microscopy of a spike protein that was degraded with an enzyme that our immune cells are using to destroy pathogens. And that enzyme is called neutrophil elastase. And that was not our finding. That was thankfully to Hammarström and Nyström from Sweden. I went to meet them, and what you can see there is the spike protein gets dissolved and converted into highly amyloidogenic and toxic fibrils, which are also very thrombogenic. And so these could be at the beginning of the cascades, at least what is directly derived from the spike protein itself. And then in the middle, you see the microclots. These are well known. First documentation was done from South Africa by Professor Pretorius and her colleagues. And what you see there are clots. They are somewhere between 5 micron and 100, 150 micron size. And they are able to occlude smaller vessels like the capillaries and other systems. And maybe that's what Charles found there. If they aggregate together, then they can form bigger clots. According to the laboratories, there's 2 laboratories that do patient diagnostics that we know well, one in Alabama, in Birmingham, and one in Germany, in Bad Aibling. And both people that run these labs say we don't find any more normal blood. It doesn't matter whose blood we take. It doesn't have to be long COVID patients or post-vac injured people. It can be anybody. And if you look at their blood, it all pretty much looks like on that slide in various degrees.
I need to pause you on that there, Joachim. So let's just go back to what you said there. So when they are looking at the blood across the board,
Yes.
they are finding that everybody has an element of microclotting.
Yes. It's very hard to find control blood. And that has changed, because in 2021 and 2022, it was still not that high percentage. So it has risen and risen and risen. So that they all have trouble now to find control blood, which doesn't show these microthrombi.
Okay, I'm going to pause. We're going to come back to the slides in a minute, but I just wanted to pull in Shankara. Based on what you've heard so far, what are your thoughts at the moment?
I think, Philip, we got a few different mechanisms at play. We've got two different kinds of clots. We've got the traditional, the microclots are reasonably traditional clots, whereas the yellow calamari clots are completely different from traditional blood clots. So I think we need to differentiate those two and how they're forming, because it will dictate treatment. From Dr. Comrie's presentation, I think we got to look at three different mechanisms at play causing the clotting issues. You've got, yes, the direct targeting of the coagulation pathways by certain proteins in the virus, so a direct coagulopathy. The second is that you have highly allergenic S1 subunits, similar to a staphylococcal B, enterotoxin B analog. And that will trigger severe allergic response, which in itself will cause the release of certain mediators, platelet activating factor being one of them. And that could trigger clots itself. And then from Dr. Comrie's presentation as well, he saw segments of the intestine that was necrosed because of ischemic injury. But certain vessels in that mesenteric vasculature were blocked. Now, why only the mesenteric vasculature and not anywhere else? Now, we know about the toxicities caused by the bacteriophage activity in the gut microbiome. Is it the gut microbiome and the absorption of those toxins that makes the mesenteric vasculature more prone to developing these kind of clots? And so we're seeing more of these abdominal symptoms. So I think it's an interplay of different things, and it all might be tied in to genetic predisposition.
Yeah, I think this is an important. The other part that I'll add, when I got the whistleblower who showed the live clots that they were taking out of patients, because up till that point I had thought that these clots were only post-mortem. But when he showed the images of the live clots that they were taking, like massive PEs and so on, I realized that this was happening in real time. And so my only thought is that from a practical point of view, a clot that size is rarely compatible with normal life. So meaning that the person is usually very sick. And the only reason the embalmers are seeing it is because these people will then die, kind of like your 72-year-old man, Charles, who then has this massive clot because he can't pump any blood through his heart. So it's not surprising that he would then die from this massive clot. But I believe the closest analogy I had to this is white clot syndrome, which is heparin-induced thrombocytopenia with formation of white clots. This is autoimmune, happens very quickly, and is quite serious. How I suspect that this is the one is because there is a case of this kind of clot forming just with COVID. So patient wasn't given heparin. They just had a COVID infection, and it somehow triggered the formation of this kind of clot. So my feeling is that in the really big clots, because we would see them on angiograms otherwise, but the really big ones happen very quickly. And if you think of your guy, Charles, how long was it before he got sick and died? What was the time frame?
That's the thing. The history given, and I'm trying to remember because it was a short history. I think it's about 4 days or something like that that he started to show signs and symptoms. I don't have his notes with me, but I think it's about 4 days. So it was very short. and he was quite well before that.
So this is a bit that is really complex to try and understand. So when we think, Joachim, about what is happening in terms of, especially what Shankara said about the gut involvement, bacteriophage involvement, I know you guys are doing some important research on identifying sources of spike protein. What are you seeing?
Now, I mean, I prepared that already 3 years ago for Pretorius, and to give her an idea of what would be the coagulation cascade that would be triggered from the disaster in the gut. And that were like 40 different coagulation pathways being triggered out of the gut, because maybe the listeners don't know all, SARS-CoV-2 is the only virus that can infect human cells and at the same time be a bacteriophage-like virus. That means it can infect and replicate in our bacteria, especially in the gut. So the bacteria is a reservoir, and you can prove that. That's beyond any doubt. Carlo Brogna has discovered and shown that. And so if you have a battlefield like that directly next to the epithelium in the gut, there will be a lot of cross reactions between that with the toxic peptides that are being excreted by the bacteria, including LPS, phospholipases, conotoxins, and many other toxic peptides, and the infiltration of the epithelium by virus, by spike protein, and the toxic peptides, and the tight junctions being ripped open. All that is a highly inflammatory thrombogenic state that will translate from there into the whole organism. But the center of that battle can be exactly there in the intestines. Yes.
So this is some pretty serious stuff. And this is why I'm saying is that from a clinical point of view, certainly whenever I think about the issue with infection and so on, one of the first things that I say to people is you have got to completely clear your gut. Just, pretend you're having a colonoscopy and just clear out as much as you can to remove the bacteria, because yes, it seems as though this is a integral part of the whole mechanism. I mean, I have never seen anything like this clinically before. This is some really strange stuff. What about you guys, Shankara and Charles?
You want to go first, Charles?
No, I mean, when you look at the range of organs that have been involved with the COVID virus, the amount of people who turned up with a cross section of organs, and it is strange. You don't get one person with you sometimes get one person with more than one organs affected, but there's always a set that will get the thyroid issues, then those with the intestinal issues, and there are a number of even people, because even recently I saw one patient who's been having recurrent diarrhea for some time, and no one has discovered what is triggering it so far. They have found nothing on colonoscopy, endoscopy, and doing all manner of tests, and everything has been normal. Autoimmune screen, everything is normal. But what is interesting, when I started to treat the person with steroids, they improved drastically. And so there's a lot of strange things that you're actually seeing. This COVID thing is weird.
Yeah. So Shankar, what do you think? Because this one of the problems, I say this especially for younger clinicians coming through, they'll be coming into the job now and they'll be seeing these things happening and they are thinking this is normal, because they don't have any template from before. So they just assume, yeah, this is what happens. What do we do? Everybody's just kind of walking around shell-shocked.
Okay. Philip, I think I look at it from the perspective of a genetic predisposition. And so I use that to educate my patients. So I find that in the unvaccinated, especially with the circulating variants of Omicron, if Omicron it's generally a mild transient illness that people actually get over. But in a subset, it triggers a response, and that response can be persistent for a long time. Now, the first three variants triggered a response that was very quickly dysregulating. The Omicron variant is almost what I'd call a slow burn. So people get the reaction, but it's not severe enough to warrant going to the doctor. And that's the reason we're seeing people saying that it took them 2 months to get over the flu the last time. It's simply because it triggered this immune response that took a long time for the body to reset itself. And I think every patient needs to know how they respond. I think that's the rub. I had two Omicron infections, and both times ended up with coagulation. There are certain patients where every single time they get a COVID infection, it triggers a certain kind of response. The sciatica either comes back or it triggers gut issues in them every single time. So I think each patient needs to know how they uniquely respond to the viruses that are out there. So I teach patients that they're having a response, they must remember what it is. And if that happens again in the future, every time they get a flu, they got to look for a response. If there's no
Now,
response, unlikely it was a coronavirus. If there is a response, they're actually able to recognize it, because these responses, Philip, might be very, very mild and go unrealized, like fatigue after the flu. A
mm,
persistent fatigue is an indication of microvascular coagulopathy. And so, I think on the other side, every vaccinated patient should have a D-dimer test done, because in my cohort of vaccinated patients, I'd say 5 out of 10 have a raised D-dimer.
that's important. Joaquin, I want you to take a look at this slide here again and just explain what this is about.
Yeah, this is a very big example of a calamari or very big clot that was pulled out of a deceased person in Alabama by Philip Triantos and Hirschman. And it's actually ridiculous that we don't have more pathologists look at this, and that we have to rely mainly on embalmers to do this. But if you look at it, you can see that the outside of this clot looks pretty, how can you say, like it has a stronger texture. And in the inside, it's still more reddish and soft. And that led me to the hypothesis to say that these clots tend to form as a lining inside the endothelial, so the inside of the vessel itself, and then slowly start to grow to the inside. On the next slide, you see some more pictures on that. And when they cut the clot in the slices and they put it under the microscope with some amyloid staining fluorescent dye under fluorescent microscopy, you can see on the left that for a big part it reacts to thioflavin, which is a sign of some sort of amyloidogenic fibrinogen mix that we're looking at. And then you see these small specks in there. And I think that could be these microclots that we see in the patient's blood circulating, and they're kind of incorporated into something I would rather define as a hydrogel or polymer-like hydrogel mass. And when you switch off the fluorescent light on the right, you see then these are very thin fibers that form this polymer hydrogel-like structure. And so we're constantly working with different laboratories. Kevin McMillan in Japan has done some work now, and he's on a new track. I haven't talked to him for a few days. I'll speak to him tomorrow, but there is new developments to define exactly what they are comprised of. Once we have a better idea what is the consistency, what they are made of, then we know more how they come about.
But one of the problems is that even they don't break down with the normal mechanisms. Isn't that right?
Looks like, yeah.
So this is now where the clinical question comes in. As I was saying, that there's some school of thought that even with microclotting that happens with long COVID, some patients respond to triple therapy. That's aspirin, clopidogrel, and an anticoagulant, whether or not it's rivaroxaban, apixaban, dabigatran, whichever one. Now, we usually only use that kind of combination in really complex, say, cardiac patients, and you know that there's a high risk of bleeding. Suppose this is where we're heading in terms of this is the kind of therapy that is needed to try and mitigate, because this is a point, even when you use it, that doesn't seem the body can break down the clots that have already formed. Clinically, what do we do?
This is a problem. The example of the man that I said had abdominal pains for months, and he had gone to a number of specialists, and nothing could be figured out. And then it just came to me, and I said, "Did you take the COVID shot?" He said, "Yeah." And I said, "I think you're having microclots." And I started him on, at the time, it was apixaban, I think. Yeah. And he did well. The pains disappeared within a week. And after a month or so, I started to use, because he had problems affording the more expensive drugs. I put him on clopidogrel, and he's been doing well. But once he stops clopidogrel, within days, the pain returns. So he has to be living on it. And once he's on it, he has no pains at all, which means that whatever is triggering his issue is still there. It hasn't gone any at all. And we're going to need to have to find out how we can clear such a patient of such a thing, because it means that one of these days he's going to miss his medication for a week, and he's going to end up with clots that are far worse than, it won't be just in his abdomen. So there's this, a good friend of mine also had multiple clots in her lungs as well. And Xarelto worked well for her. But then there's another patient who was on, I think it was both Pradaxa and was on clopidogrel and was still getting clots. I have a friend of mine, his mother has gotten now, I think perhaps the 5th stroke, and she's well anticoagulated as well. And I think she's on triple therapy, and she's still getting clots. So I agree with Dr. Chetty that I think this thing is everybody is responding a little different. Genetically, perhaps that's what is triggering it. And so some of the clots may actually be more platelet derived, and some may not be. And I think this is what is going to come out. And but how do we find out?
This is a problem. How do we know? You were going to say something, Joachim?
Yeah, an observation we had, of course, and that's what Robin should normally talk about today, because that were her patients. So we could find out that through this regime of dietary supplements, which are shown to take spike protein out of endothelial cells, out of intracellular space, especially in the endothelium, that this is one big factor fueling the endotheliitis and the formation of microclots. So spike in the serum, of course, because of the amyloidogenic nature of it, plus persistence in the artery walls, for example, which will fuel this. So if you take that intervention, automatically the microclots go down drastically. And so we are not trying to so much to take them apart. They also are breaking up, but we want to stop the formation of that. We want to go to the causation of this, and that is most of the time persistent spike protein in the endothelium. And because it is in there, it had broken before the glycocalyx. And when the glycocalyx is gone, then you have a lot of reactions between the endothelium, inflammation, migration. You have a thrombi formation on the endothelium. So you have to take out the spike and restore the glycocalyx as soon as possible. And why you see some patients being so bad and others not is because anybody that has a chronic disease, inflammatory disease, autoimmune, intestinal driven, just name it, diabetes too, will all have problems with a degraded glycocalyx. Their glycocalyx is damaged to start with. So they are much more susceptible for the spike protein to get in. And once the spike protein takes foothold in your endothelium, it's like a bushfire. It's like a chain reaction. It will upregulate an enzyme that will then degrade further your glycocalyx and then open up the way for more spike to get inside. And so it's going to get worse. And so this endotheliitis, the endothelial inflammation, is one of the biggest driving factors, because in the presence of spike, you have also some things like protein C, which is a rare disease, is downregulated in most of the COVID and non-COVID patients, and that is a protein that will disaggregate thrombi. So we have thrombi formation and the inability to break them down, both being triggered by the same toxic proteins here.
Now, an important question here, because I know what work is being done through medicinals, and Joachim hasn't even said anything about it per se, but I think it's important to highlight that they're doing a lot of work in the background as to how this can impact on the removal of spike proteins. But take that aside, in the clinical context, you are not going to find most doctors are prescribing any nutraceutical supplements. All they've got in their toolbox is antiplatelets and anticoagulants. Is it enough, Shankara?
I don't think so, Philip. I think the mechanisms that are at play, I think we discussed this right at the start, that the pharmaceutical interventions are too targeted. And there's many mechanisms at play. And of course, we're looking at a persistence of spike. We're looking at cells that have gone into senescence, that are harboring the messenger RNA. So a lot of the work Joachim is doing is looking into how to remove that spike, removing the senescent cells producing the spike. So we got to remove the root cause, which is the spike protein. So and of course we've seen that the virus hijacks many of the body's protective mechanisms, interferon responses, a wide variety of different things. So it reminds me of the California bushfires, and the dam was drained. Something nefarious going on. So if this particular coronavirus has attributes, many different attributes that no other coronavirus actually has. And so, yeah, it's a completely new ballgame that we're dealing with. But the bottom line is the offense comes from the spike protein. And it might have genetic predisposition, but we've got to understand how it influences everything.
Here's a question for you, Charles. Now that I think about it, because there is clearly an inflammatory process that is driving this along. Is this a situation where we should be, if the medical community was on board, where we should be using more heavyweight immunosuppressants, not necessarily steroids, because they have a lot of side effects, but steroid-sparing drugs, methotrexate, cyclophosphamide, to try and so almost managing this more as a vasculitis rather than just, it's kind of like if a patient had vasculitis and you didn't address the vasculitis and only used anticoagulation, it wouldn't work. Do we need to target the inflammation as well?
That's an interesting question, because one of the things I remember when the outbreak just started, and they said, oh, all the people with chronic diseases and so those with autoimmune illnesses and stuff were going to start dying more rapidly. And I noticed that the people who had lupus and such illnesses were not dying quickly. In actual fact, less of them were ending up in hospital. And of course, a lot of them were on hydroxychloroquine, which some of us know would have helped the situation. And it may very well be that it was because it was helping with their autoimmune part of their disease. And it is quite possible then that we probably should consider it as an option and say, let's hit the autoimmune system a bit harder, especially those who seem to be more vulnerable and getting repeated attacks and are coming back with symptoms as soon as you treat them and they're okay, and 3 months pass, they come back again. So yes, they obviously need a more long-term management, and I think it should be considered. Yes.
And Joachim, is when we look at this ongoing with your calamari project, you have here that is this more of a hypothesis that this, this is like the hydrogel that is being formed in these arteries, and I guess over a period of time. And so what do we think is the mechanism that dislodges it? Because it's the dislodging that would then, because if it's like this, people will be fine. They don't know. They have no symptoms.
I wouldn't know. I mean, it seems to kind of replace the glycocalyx getting stuck directly to the endothelium and building up. So it can dislocate, of course. Usually the blood flow goes, in many parts, goes from wider to smaller. So I wouldn't know. But if you, for example, if you try to break something up like that, it could then go and clog vessels with a lesser diameter. So I wouldn't know. We are still in the process. I want to, Charles. So if you look next time at a deceased person, where you look closer, see if you can find these clots in the stage of forming in the organism. Yeah, that's why I drew this. I wanted to give them an idea to what to look for. Yeah, because nobody has found those yet, or looked for them even. You just have the big ones that are pretty solid, but you want to look at some of the blood vessels and see if you have already some kind of formation there ongoing. I think it's only possible because of the inflammation and the presence of spike in the endothelium in the first place. That's why this can get stuck there. Otherwise, it wouldn't even hold. You need the glycocalyx that needs to be gone for that.
You know, one of the worries I have with the involvement of the vascular endothelium is that it's a slow turnover area. It takes about 6 months to turn these cells over. And so even if you had a mechanism to manage them, you have to be using it for at least maybe 6 months to a year in order to get patients beyond it. We are so far away from having any kind of clinical protocol. People don't even want to accept that this kind of thing is happening, much less to be looking at any protocols. What are patients to do?
I think, Philip, a lot of patients are clueless about what's going on with them. They present with fatigue. I've got patients that come to me with symptoms that have been lasting for the past 2 years. Abdominal upset or numbness and tingling in the periphery. And strangely, they've had all manner of tests done. From ultrasounds to CTs, visited every specialist, done all the blood tests, can't find anything wrong. But they come to me fatigued. And from the start of the pandemic, we spoke about 3 tests. C-reactive protein for inflammation, interleukin-6 values, and your D-dimer. And strangely, with 2 years of investigation, those 3 tests are not done. And when I do those 3 tests, invariably one of them is elevated. And you know where to act. If it's interleukins, then you know it's more an autoimmune or immune-mediated type of condition. If your D-dimer is high, guy's having clotting issues. If it's a combination of the two, well, you're going to have to act on both. But I don't know why the medical fraternity hasn't caught up with this. I guess in the next few weeks to months, when they realize what has actually happened, they'll have to actually stand up and start to protect their patients.
You know, one of the reasons I like listening to Shankara is he just says something so casually there, like, you know, the CRPD dimer interleukin 6 and the integration as to how they work. That in itself is a protocol, you know, but the clinical community would have to acknowledge it and be willing to address it. So when you think about it, Charles, are you still getting pushback about the observations that you have made about these clots? Is anybody even interested in it?
No, they're not interested. It's a few months ago, and remember, from very early in the onset of the illness, and the the shots were given, and I begged them. I said, can we start doing blood tests? I said, can we get 100 patients and let us do weekly blood tests on them? Because I know the funding was there. I said, just get 100 patients and just do their blood tests over 6 months weekly, so that we can see if we can find a pattern as to what may be happening. And they refused. And I mentioned it again after. And a few months ago, I also mentioned it to somebody from the ministry as well. And I said, I am still seeing patients whose vitamin Ds are still dropping low. And even after we top them up and it's gone up, and 3 years later, we see it start dropping again, vitamin D and vitamin B12. And up to last week, I had patients coming in with their vitamin D in the early teens, and they have these weird symptoms as well. And some of them have anxiety issues, some have depression, and they're just feeling generally unwell. The brain not they have brain fog, and all these things. And you check their vitamin D and B12, and they're low. And the doctors are not checking it, despite the fact that they've heard it from other doctors that, look, double check, because it's dropping it. And it's as if they don't care. They're still doing so many tests. And the patients come, and I said, have you checked your vitamin D? They said, no. And I send them, just do your vitamin D and B12. And it's through the floor. You start them on to top them up on high doses. And within a week, they call you and they say, I'm feeling much better. And this is part of the whole thing of why I'm saying that this thing is so nefarious in terms of how wide it affects the body, this virus and whatever the shots afterwards. In that, yes, we can check the CRP and all of those, because they're signs that there's inflammation. If your vitamin D level is low, your body is also going to be inflamed all over the place as well. If your vitamin B12 is dropping, it's going to affect your nerves, your brain, and everything. The problem is those are the only two I can get tested. Obviously, some of the other vitamins are dropping as well. Why? We don't know. And this is where now even the clotting system, because you need some of these for as catalysts for some of these reactions. You have the calcium, your vitamin D's and stuff, and you're saying, well, which one of them is it affecting vitamin K as well? Do we know that? Nobody has tested that. So we don't know if that pathway is affected either, one way or the other. And it's as if nobody cares to find out. And everybody...
it's a difficult one, I think I'm trying to get my head around it. I think it's just that I think the lesson I have learned from observing the pandemic is that for most clinical people, they didn't need to think anymore. There was a protocol for COVID. There's a protocol for this. There's a protocol for that. And there's almost now a dependency on protocols. And if there are no protocols, if there is no acknowledgement from the significant scientific community, even if they are seeing it, it is irrelevant, because they have no framework in which to treat. And that's about defensive medicine. But in the middle of this mess are patients, and a lot of people are sick with nowhere to turn, nothing left that they can do. And I can ask you this question, Joachim, is that your background is engineering, and you have come into this with a pure scientific mind, just trying to look and trying to solve. What is your independent opinion after observing what has happened from the clinical community across the world?
I mean, it is actually it's a good thing in one respect, because it shows that the compartmentalized healthcare system has no chance at all to cope with this multisystemic disease, not a single chance. And so that is good, because it will, by force, bring the healthcare systems in the direction where I'm working, or our colleagues are working, which is an integrative and multi-level targeting of disease and looking for the root cause. Look, if you look at the thrombi formation and the clotting cascade, if you remove the spike protein from the organism, which is the root cause for that, you will not address everything, but you can observe at the same time, while the spike levels go down, you can see a strong decrease also in the microclotting, for example. So always go upstream. Now, what we are used to is symptom management and looking at the disease expression and start from there. I don't care about that. I look at every mechanism and try to stop and address it and correct it. And then automatically everything else will fall in place. But most people are not willing to do that, because it's a tremendous amount of work. You need a lot of groups that you can work with in the neurological, cardiovascular, metabolic, and other, let's say, sectors, and then combine all that. So go upstream, take care of the root cause of the system, strengthen your organism, bring your organism back to a healthy state. The problem is that the exposure to SARS-CoV-2 or spike protein is dysregulating over 10,000 epigenetic settings at the same time. So of course you see a firework of problems. Yeah. So only nature holds the real key to that. If I look at everything they want to do, the idea of synthetic biology is actually ridiculous, just the word. Yeah. We are biological beings, we are nature, so why not use, first of all, the best things we can find in nature? Because each compound in nature will address at least 20, 30, 40 mechanisms at the same time. Get those in a good dosage, you choose the right compounds, the right delivery methods, and the right protocols in this case, because even there you have to have a systematic approach. But that is one of the biggest potentials we can use in this, in the trying to mitigate the fallout of this pandemic, and it's still ongoing. I mean, the pandemic is not over with. At the contrary, we have more infections every year now than in all previous years in this pandemic. So it's the opposite of over.
Yeah. And so, Shankara, when you put on your head, not as a clinician, but as a patient, because this is who is here. We have a lot of people listening. You have over 750 people with us live at the moment. What do they do when their clinicians or their doctors are not open to doing this? Even to get the D-dimer done would be a struggle to get the doctor to do it. What do they do?
I think, Philip, it's going to bring the medical fraternity to a crossroads. You don't go back to a doctor when he can't solve your problem. And so a lot of the doctors that refuse to look at this are going to become irrelevant over time, because a majority of the world's population took the vaccine. And like I said, we've altered the physiology of the planet, so doctors need to relearn the physiology. Otherwise, you're going to become obsolete. And so I think there's going to come a time where they're going to have to swallow their pride and egos and start to look at what's actually transpired.
Charles, what would you tell? You have a relative in the US, say, they don't know what to do. What do they say to their doctor?
No, I'm a little bit more blunt. I tell them, you walk in and they see certain things, you take your money and you leave and go somewhere else. Because unless, and it's sad to say this, but unless doctors start feeling it in their pockets, they will not start thinking. And that is sad. So they have to the patients have to take their health into their own hands and say, hey, look, if you're joking with my health, I'm not coming back to see you. And they also have to recognize as well that they need now to do the things that are right for them, the things that are simple and basic, as Joaquin was saying. It's nobody's promoting a proper healthy diet. People going out in the sun or whatever and taking vitamin D if they're not exposed to the sun. Topping up their diets, because obviously our diets are very restricted now in a lot of minerals and stuff, and we are not supplying ourselves with the nutrients the body needs to repair itself. I'll give you a quick example. When patients are on warfarin, they always tell them to come off these colorful vegetables and whatever, because they said, oh, you're going to get vitamin K. And because of that, it's going to fight against warfarin. And I remember one patient, I said to them, well, please go back to the doctor and ask them, how do you get your vitamins? And the doctor was stumped and said, well, you're going to have to take multivitamins. And I looked at the patient and said, that's a joke. How can your body repair itself if it's not getting adequate amount of vitamins? So all my patients who are on warfarin are on any form of, they are on all the vegetables and fruits. And all I do is just regulate the amount of warfarin that I have them on. And I tell you what, most times within a month, their clots are gone. So I don't have to have my patients on medications, on warfarin for 6-9 months. And I have patients 2 years and they still have their clots and their diets are so restricted. It's horrible. And because many doctors are not trained in terms of dietary stuff and how and natural things that can actually help, then we have this struggle, which does not have to be there. I had patients come in from the UK and they say, oh, they were taking garlic, onion, and omega-3 to thin their blood, which it does. And the patient said, and the doctor told them, no, you can't do that. You will thin your blood too much and bleed. So you have to stop those and let me put you on aspirin. And I'm like, what? And so we are disconnected from the reality that of what the diet should be and how people should actually look after themselves. And as you said, we've become, as one patient called them, they said, you're just medical technicians. You just go, you get these protocols and you just follow them. So you're not doctors anymore. And it was a shocking statement from the patients, but then I understood what they meant, because everybody just follow protocols, as you said earlier. And so they will just look up what is this and just write it. And in terms of actually differentiating the fact that, look, all your patients are different, and therefore that's why you're a doctor. You're supposed to recognize the difference with all your patients and then adjust to fit the situation. And we've gone past that. We no longer practice medicine. I'm not sure what we're practicing.
Yes, it is scary times, and I think it's just the fact that everybody is feeling outside of their comfort zone, and they don't want to acknowledge that they're outside of their comfort zone. Because if what we had as our template was all these studies, you know what it's like in medicine, we can fire off, oh, this study showed this study showed that, and if all of the studies now are null and void because physiology has fundamentally changed, that is very scary for
Yeah.
people whose foundation was the use of these studies to direct and guide patients. It's very scary. And so I think that there is almost a sense of deer in the headlights kind of experience at the moment. But truthfully, similar to what happened at the beginning of the pandemic, you need the clinicians to just step up. They just
Yeah.
need to forget about, okay, who said, let's just step up. Let's try and see if we can understand this. Let's see where we can go with this. Now, we're going to close out now. And I just wanted to take the opportunity Joaquin. And for anybody who is interested, because I am working closely with what he's doing with his products and critically his testing. This is what I know is coming in the background for people who are interested. Tell us in a short summary what it is that your company is doing and what is your vision in the next few months to a year.
Now, first of all, we were talking about spike protein and even persistent virus, of course. And let's say one of the qualities of this virus is, and the spike protein, that it switches off any kind of mechanism that we have to get rid of it, so to dissolve it or to disaggregate it. And so that is one of the biggest problems. That's why it persists so long. So we have now developed actually, or have teaming with other teams, 3 different methods of detecting spike protein. And so some of it is in the free serum, which is not the most part. The biggest part is actually stuck in the cells. So we have also developed a new methodology for provocation. And so there will be different tests. There's a dry blood test already ongoing as a scientific research project in some countries, including the US, and we will start that also in the UK now. So you can send dry blood and we can have a look if there's spike present in that blood sample. We can distinguish between spike from the virus, spike from the vaccine, and tomorrow I will know spike also from the bacteria. So that's all in the hands of Carlo Bronia and his colleagues Simone. And so that's ongoing. Then I have myself started a project here for a spike quick test, which is in production. So a few weeks we'll have that available in Europe, already certified and compliant. So you can prick your finger and check if you have spike protein or not. And then there is also the laboratory in Germany of Brigitte König, where we are working currently. That's a real diagnostic lab for patients. And we have already now many months with her that we show, we look at spike in the exosome, spikes in the immune cells, and also spike increases when we provoke, and so on. So this looks really good to get rid of the spike intracellularly. Has shown, we have published already some papers now, some patient reports. And so we're working on measuring and getting rid of spike at the same time, which has shown quite some benefit for, especially for the coagulation as the root cause of it.
Excellent. Thank you very much. And Charles, what are your thoughts, final thoughts that you would say to the public?
Make sure you're eating properly. Make sure you're taking your vitamin Bs, your vitamin Ds, and make sure you're going outside, you're exercising, doing all of these things, because in the long run, these things help. I mean, remember, even exercises help to reduce inflammation. Vitamin D does. A lot of these things does as well. So we have to help the body to fight whatever we have now gotten. We can't live in the past and saying, oh yes, this we have this. We have to now say, okay, it's gone already. Now that it's in your system, how are we going to move from there? And this is why I'm glad to hear that we're coming up with ways of detoxing the body, because it is necessary, because people are dying and people are having chronic illnesses. And it's not going down, it's getting worse. So for the patients themselves, make sure that you give your body the adequate amount of rest and everything that is necessary for the body to repair itself and to keep inflammation down. That's their duty. And then us in the medical field, we have to step up and see how we can help the patients.
Yeah. And Shankara, your final thoughts?
I think Dr. Comrie is exactly right, Philip. We need to go back to basics. What's transpired over the last, say, 50 years has taken us backwards as far as medical progress goes. We've got more illness, we've got more heart disease, we've got more cancers, we've got more chronic illnesses than our great-grandparents had. So I think go back to living like your great-grandparents did. And the first thing you need to do is throw away your cell phone and stop them influencing you so much. But yeah, back to basics. And I think doctors need to step up, learn. We need to figure out what's happened. We've got people like Joaquin that are looking for solutions, developing new products. So yeah, I think it's a hearty collaboration between all the people that are awakened in the world that's going to save the day.
Excellent, excellent. Thank you all very much. Really appreciate you all coming. For those people who are interested in finding more out about this spike thing, there is a link in the description that you can do a survey, and I'll then be able to contact you by email. There is a lot of work that needs to be done in the future, well, now and in the future, to resolve this issue. I think we're just scratching the surface, but we are very appreciative that there are people working hard to try and find solutions. So again, thank you all very much. And I'll just ask you to hold on with me while we do the outro. Thank you, audience, and we'll bring you more information in the near future. Have a good evening.
Thank you.
Okay.